Okay then. Knowledge check again. A patient is administered with drug A to treat his acute exacerbation of asthma. Which of the following best describes the receptor drug A interacted with? And the answer, as you had said, it is a surface membrane receptor. Okay, so we'll go on to the next one. This is to recall or recapitulate what we said yesterday. There are four mechanisms by which drug actions occurs. It's through receptors, through carriers, through ion channels and enzymes, all right? And you can see in the blue panel, we're still on receptors. We've talked about surface membrane receptors. We've talked about ligand-gated ion channels, G protein coupled receptors, and now we're on to linked to enzymes, receptors that are linked to enzymes, okay? So this is the example that is used to illustrate enzyme-linked receptors, and this is how tyrosine kinase works. Tyrosine kinase is it's a molecule, it's an enzyme which is related to stimulation of growth. All right. So this is the arrow here points to the tail end of the receptor. The whole thing, the U-shape red structure, the yellow structure, the blue structure refers to or depicts the receptor, and tyrosine kinase is at the tail end of the receptor. All right. So when you have an effector molecule that can stimulate the receptor, let's see what happens. There you go. There's an agonist, and when it is stimulated, the tyrosine kinase will be phosphorylated. All right. And this will activate tyrosine kinase and adapt and attract adapter proteins. The yellow ball here is adapter proteins, and adapter proteins will stimulate what we call MAP kinase or mitogen activated phosphokinases. You don't have to know the details, okay? This is just to illustrate to you how enzyme linked receptors work, all right? So when MAP kinases is activated, this will cause gene transcription, and when you know, I think from school, from your secondary school or from FIS, from your science A levels or whatever matriculation or pre-university courses that you went through, you would know that gene transcription is used to produce new proteins are synthesized, which stimulates cell growth. So tyrosine kinase, I'm sorry you can't see the full slide, okay? When tyrosine kinase is stimulated, what happens is gene transcription, and when there's gene transcription, there's new protein being synthesized, it stimulates cell growth. Now I want to draw your attention to tyrosine kinase. So the end product of tyrosine kinase being stimulated is cell growth. Can you see that? Any questions on this slide? Yes, no, don't know?
No, doctor.
All right. Okay, that's good. Okay, so tyrosine kinase does all these things here, ends in gene transcription, ends in stimulation of cell growth. Now, why? There's a reason for stressing cell growth, is because I want you to identify something, okay? So let's identify drug targets. This is how drug development occurs. When you use an agonist, just like this is an agonist, and it's called an effector molecule, whatever it is that stimulates the receptor that is linked to tyrosine kinase. So an agonist stimulates the receptor, it causes cellular response, and this leads to stimulation of cell growth. All right. So when you want, if there is a situation where you need to stimulate cell growth, you will use an agonist to stimulate tyrosine kinase. But what happens if you have excessive cell growth, like in some cancer situation? What can you do? Come on,
We
guys.
can use an antagonist.
Exactly. Excellent. So use an antagonist. And when you use an antagonist, what will happen? When you use agonist, you increase cellular response. Antagonist will?
Decrease cellular
Block
response.
cellular response.
Exactly. So that blocks cellular response. Very good. And so what happens? Will it stimulate cell growth?
Exhibit the cell growth.
Pardon? I beg your pardon?
Exhibit the cell growth.
Inhibit the cell growth, right? Okay. So it reduces, sorry? Yeah, so when you block cellular response, when you increase cellular response, it stimulates cell growth. When you do the opposite, when you block this whole pathway, what you will do is you will reduce or slow down cell growth. And this is actually, this has got a clinical application. When we use tyrosine kinase inhibitors, we use it to treat chronic myelocytic leukemia. And the biological agent or the drug is called imatinib. All right, so this is I thought, instead of just telling you what kinase linked receptors, I would also tell you that this is how drug development occurs. All right, we make use of the receptors and the pathways and the cell signaling. We suppress this and we stimulate that and we come up with drugs. Any questions on this? Okay, otherwise we'll move on. So now we're done with receptors that are located on surface membrane. We're done with receptors that are on the surface of cells or membrane of on cellular membranes. All right. So we move on to intracellular receptor. Intracellular receptor affects gene transcription as well, just like the one that is linked to enzymes, but instead of in the membrane, it's in the cell. So what do you think the property of the drugs would be if the receptors are in the cell? I asked this question yesterday and you got it right. Can you still remember?
It should be lipophilic.
Exactly, very good. It has to be lipophilic, is lipid soluble, right? Okay, so the examples that we use would be steroids. Now, steroids, we know we have glucocorticosteroids in our body, and that's produced by the adrenal glands, but we also give steroids to patients in some conditions like systemic lupus erythematosus or very bad asthma patients will get steroids. So let's see how it acts. First of all, glucocorticoids regulates gene transcription. Remember that, and it's located intracellularly. I think it's pretty easy to remember because it's the only one that you're taught that the receptor is in the cell instead of on the membranes. So glucocorticoids will cross the membrane and attach itself to the receptors in the cell. All right. Now, before it can do its job, when it attaches itself to the receptor, before it can do anything at all, it has to undergo changes in conformation, which just means, it's a big word, which actually just means it changes its structure. Okay, that's a structural change. And I have depicted with two triangles here. It's not necessarily true, but I just wanted to emphasize to you there's a structural change which allows this element to come into the nucleus. All right. So GRE stands for glucocorticoid response element. This whole complex is called glucocorticoid response element, and it involves conformational change of the structure. And when that happens, it enhances the interaction with DNA and alters gene expression. All right. So when glucocorticoid response element comes into the nucleus, it attaches itself very well to certain part of the nucleus, and this will cause gene transcription. There you go. And what does gene transcription do? It also causes synthesis of new proteins. Now you'll have a whole lecture, and I think that's happening in semester 4, where you will learn about the pharmacology of corticosteroids, and you will be learning about the mechanism of action again. But for now, it's enough for you to know that it's intracellular. It causes gene transcription, which leads to synthesis of new proteins. which will affect and give clinical responses. All right, we're done with receptors. Any questions so far?
Doctor, I have a question.
Okay, sure.
So the enzyme-linked receptors also can affect gene transcription, am I right?
Yep.
Okay,
That's right.
thank you, Doctor.
All right. Okay. I don't have to go back there. So we're done with receptors. Now we move on to the mechanisms of drug action, carriers, ion channels, and enzymes. Okay, and these are mediated through it's not mediated through any receptors. The drug can directly affect the carriers, directly affect the ion channels, and directly affect the enzymes. Whereas this part in the blue panel, the drug has to interact with the receptor before it can give its provide any clinical actions. All right. So this is LO2 again, explain 4 mechanisms of drug action. We're finished with receptors and we're now going on to the non-receptor mediated mechanisms of action. Okay, carriers are just simply transporters. They're like cars or lorries or any vehicle. It just carries the drug from outside of the cell to the inside of the cell. It's not lipophilic, so it needs something to bring it into the cell. So this is what happens. It attaches itself to the outer part of the carrier, and then the carrier flips inside. You see, there you go. It flips inside, and then it releases the drug. That's pretty easy to understand, don't you think? Yes, no?
Yes, Professor.
All right.
Yeah.
Okay. So that's very easy. I think the receptors are the most, some students find it more complicated, but I think the non-receptor mediated mechanisms are pretty easy to understand. So this is, it just transports drugs that are not sufficiently lipid soluble or too polar. It requires carrier molecules to transport them. It just cannot cross the membrane on its own. So it needs some carrier mechanisms, okay? And I want you to do that, to do some homework, look up some examples. Now it's drugs acting on ion channels. Some drugs produce the actions by directly interacting with ion channels. If you remember, there was also an ionotropic receptor, but it involved a drug acting via the receptors, and that affected the opening and closing of the ion channels. But in this case, there's no receptors involved. When you see the calcium channel here, the 2 brown bars here are calcium channels. There's a binding site where the drug can go and bind, can sit straight away. This is not a receptor. It just binds to the binding site of the calcium channels, and what happens? It closes the channels. And when it closes the channels, the calcium cannot come in. And why don't we want calcium to come in? Can anybody think? What does calcium do?
Is it
For
for muscle
muscles.
contraction?
Exactly. So what happens when calcium cannot come in?
Muscle relaxes.
Exactly. So we have a muscle. You can relax the muscle. In this case, we're talking about the smooth muscle, right? Smooth muscle. And nifedipine is a prototype of calcium channel blockers. When we use nifedipine, calcium cannot come into the vascular tissue, and there will be vasodilation or relaxation of the smooth muscles of the vessel system. And what happens? What do you think happens then when there's vasodilation? Come on, guys.
Blood pressure drops.
Exactly. So that's exactly what nifedipine does. Nifedipine, diltiazem, verapamil, amlodipine, they're all calcium blockers, and it's used very, very widely in the clinical setting. And I'm sure in whatever specialty you're in, whether it's ONG or you're in internal medicine, infectious disease, whatever you do, you'll be using calcium channel blockers. I'm very sure of that. And it's very simple. The mechanism of action is really simple. It just goes and sit on the binding site at the calcium channel, blocks the entry of calcium into the L-type calcium channel. All right?
Doctor.
Yep.
I have a question regarding that. So, calcium ions are actually involved in in the vesicle formation, right? So, wouldn't that be also affected by this drug?
I know what you mean, because when we need calcium to come in, and then the vesicles will fuse with the membrane, releasing neurotransmitters. Is that what you're saying?
Yeah. So, wouldn't
Yeah.
that be?
But this is a special type. It's the L-type calcium channel.
Oh no.
Nifedipine is blocks only the L-type calcium channel, which is found on the myocardium and the vessels only.
Okay.
Right.
Okay.
Okay.
Thank you.
Yeah, sure. And
So
this is the
doctor,
last.
nifedipine is not used as a muscle relaxant, is it? It's more of like for the lowering of blood pressure.
Yeah, it acts
Okay,
more on
okay,
the smooth
got it.
muscle. Yeah. Okay. Yeah, you'll have a whole lecture on calcium channel blockers. I think it's soon in semester 2. I think, and when you learn about cardiovascular drugs. Okay. So the last one is drugs acting through alteration of enzyme activity, and the example that I've chosen here is something that you will hear very, very soon. So this is this enzyme. This cylinder here depicts an enzyme, and this enzyme is called acetylcholinesterase. And enzyme will have a substrate binding site. So I've drawn the substrate binding site on the enzyme acetylcholinesterase. And so the job of acetylcholinesterase is to metabolize acetylcholine. All right, it breaks down acetylcholine into choline and acetate. That's the job of acetylcholinesterase. Okay, let me go through the slides first. You can ask the questions. I just have a couple more slides. Okay, so acetylcholine, when it binds to acetylcholinesterase, what happens is acetylcholinesterase will break it down, will metabolize it, will degrade it, whatever term you use as you like to use. You can use degrade. Acetylcholinesterase degrades acetylcholine. Acetylcholinesterase metabolizes acetylcholine. Acetylcholinesterase damages or destroys acetylcholine. All right, but the best word to use is metabolize or degrades. So acetylcholinesterase will degrade acetylcholine. But in some instances, some patients, they don't have enough acetylcholine, and we do need acetylcholine for muscle activity. If you don't have enough acetylcholine, one of the conditions that will cause is, does anyone know? If you don't have enough.
Myasthenia gravis.
Exactly. Fantastic. Yeah, it doesn't have. People with myasthenia gravis, they don't have enough acetylcholine. So what do you think we want to do? What do you think we can do? Do you
Provide
want
them with more acetylcholine.
Yeah, we could, but when let's talk about acetylcholinesterase. What can we do to it?
We can block the body side.
Yes, we can block the binding site. We can give a drug that instead of acetylcholine binds to acetylcholinesterase, we'll get that drug to do the job of binding to acetylcholinesterase. So acetylcholine cannot bind to acetylcholinesterase, and if acetylcholine cannot bind to acetylcholinesterase, it will not be broken down. Get it?
Yes.
Yeah.
Right. And this drug is called, one of these drugs is called neostigmine. All right, the structure is similar to acetylcholine, and that's why it can compete with acetylcholine for the substrate binding site on acetylcholinesterase. So when neostigmine combines with the enzyme, what happens? Simple, acetylcholine is not broken down. And what happens when acetylcholine is not broken down? There will be increased levels of acetylcholine at the synapses, right? And then you have you can neurotransmission can occur. All right. So do you have any questions on drugs acting through alteration of enzyme activity? Now it's quite straightforward, isn't it?
Yes, Professor.
Yep. Okay. Knowledge check. A patient with a condition known as myasthenia gravis was given a drug X, which improved the level of acetylcholine, which is ACH at its synapse. Which best describes the action of drug X? A, it is a substrate of the enzyme which metabolizes ACH. It inhibits the enzyme which metabolizes acetylcholine. It increases the synthesis of acetylcholine. It behaves as a neurotransmitter. What does drug X do?
A.
What about B?
Yeah.
A is correct, but if you were to be asked which best describes the action of drug X, and you know in myasthenia gravis you have to increase the levels of acetylcholine at the synapses, all right? So the correct answer, if it is a true-false answer, I agree with you. A can be correct, B is correct, C and D is wrong. But if it's a one best answer question, it will be B. It inhibits the enzyme which metabolizes ACH. Because you do know that you want to increase levels of ACH in a patient with myasthenia gravis. Do you understand?
Yeah.
Doctor?
Yep.
If it's a true or false scenario, why would C be incorrect? Wouldn't that also have the same effect?
No, it doesn't do it. Acetylcholine is synthesized from choline and acetate, and it doesn't, neostigmine or drug X will not increase the synthesis. It prevents the breakdown of acetylcholine.
Yeah, but like assuming that we don't know what drug X is, wouldn't C be correct?
Oh, I see what you mean. No, if we don't, yeah, but we know that there are no drugs that increases the synthesis of acetylcholine. Okay.
All right. Thank you.
Yeah, it become more obvious to you as you progress through the medical school. All right, but I get your point. So the last LO, right, is explain the process of receptor regulation and functions of receptors. Now, this is a whole mouthful to me of the learning objectives, but all it means is, what is the process of receptor regulation? All it means is whether there's up regulation or down regulation. That's all it means. That's the process of receptor regulation, okay? And functions of receptors, we have gone through the functions of receptors. When we talked about membrane, surface membrane receptors, when we talked about the intracellular receptors. But this function of receptors is what happens when there's up regulation of receptors and when there's down regulation of receptors. But before we know what happens, why it happens, we first have to define what is up regulation and down regulation. So up regulation of receptors would refer to the increase in the number of receptors on the cells, making it more sensitive to ligands or drugs. It's simple, isn't it? When you have more receptors, there are more ligands that can bind to receptors, so the organ will be more sensitive to the agonist or to the drugs. Do you get that? Upregulation of receptors refers to increase in the quantity of receptors, which makes the organ or the cells more sensitive to the receptors, whether you use antagonist or agonist. Did someone want to say something just now? Can you see this diagram here? Upregulation. It first have 2 receptors, and then it has 4 receptors, and then it has 2, 4, 6, 8 receptors. Okay, this is an increase in the number of receptors, and as the number of receptors on the cells increase, the cells will be more sensitive to the ligands or drugs that can activate the receptors or can antagonize the receptors. Downregulation is the opposite of upregulation. Downregulation is to reduce the number of receptors, refers to the reduced number of receptors, making the cells less sensitive to ligands or drugs. And this is depicted by the lower part of the diagram, downregulation. We first have a lot of receptors, and then over time, we have less number of receptors. All right, I'll go to the next slide, and then you can ask me questions. So process of receptor regulation and functions of receptors, and these slides will just give you very simple examples of why it happens and their implications. And these are just examples, okay? So upregulation happens when there's prolonged use of a drug which is an antagonist, and the body realizes that the agonist is not getting the chance to combine to receptors because an antagonist is present. So the body recognizes this and it increases the number and sensitivity of receptors. So my question to you is, what happens to the effects of the antagonist?
Is the effect, sorry, is the
Somebody
effect
said,
of the
sorry, come again?
sorry, is the effect of the agonist, does it overshadow the effect of the antagonist then?
Yeah.
Does it become less significant?
Yes, and someone actually said lowered just now. I heard a small little boy saying lowered, and that's right, okay? When there's prolonged use of drug, you have more receptors and you need more antagonists to act. But if you have, let's say you have only 500 molecules of antagonists, when there's only two receptors, when there's only 500 receptors to act upon, you have 500 molecules and it acts well. But when you have 1,500 upregulation of receptors, but you still have only 500 molecules of antagonists. So do you think the effects will be lower or higher?
Should be lower.
Yep, exactly. It should be lower. What happens to the effects of the antagonist? It will be lowered. It will be lowered because it needs to combine to more receptors in order to exert its effects. Okay, so downregulation. Now, upregulation and downregulation of receptors, you'll be coming across it. Now, these are just concepts, and you'll be coming across it when you talk about the systemic drugs. Okay, why some drugs over time become ineffective. So downregulation is prolonged use of agonists. Say you have prolonged use of agonists and the body recognizes as, say you give a patient bromocriptine. Bromocriptine is a dopamine agonist, all right? So the body recognizes as too much of bromocriptine, prolonged use of agonists, prolonged use of a dopamine agonist. So what it does is it reduces the number and sensitivity of receptors of dopamine. Okay, this is an example. So what happens to the effects of bromocriptine, which is the agonist, dopamine agonist?
Would it become higher?
Prolonged use is down regulated. There won't be enough. There won't be many receptors for bromocriptine to act.
Oh, sorry. Yeah. So it's lowered.
Yeah. Okay. So, but these are just examples. If you read the books, you'll find examples that it can increase or lower some drugs. So I thought I'll just give you examples and will not. I had not even want to mention bromocriptine or dopamine agonist to you because this the first few lectures of pharmacology is tricky, I think, and you need to understand a lot of concepts and phenomenons and principles, and so we don't want to use a lot of, or at least I don't want to use a lot of drug names at this point in time. So I think that brings us to the end of the lecture. Have you got any questions for me? Or otherwise, I'll see you again on the 17th of June, I think. I've got 2 hours of lectures with you on the 17th of June. And then if you've got questions, if you have read through and discussed with your friends and read through referred to your text and you still don't understand, you can either call me through Teams or ask me through Teams before the lecture, or you can ask me during the second lecture, because these 2 lectures that I have with you is related. So I have a feeling that we will not use up the whole of the second hour. Okay. But of course, you can ask me before that, and I'm very glad that I had some questions I had quite a number of students asking me questions from yesterday's lecture as well. Yesterday's part of the lecture. Spare receptors. We're not going through it. I want you to go to the books and please read about it. And yeah, if I have time, I'll try making a micro-learning package on it. But meanwhile, please read about spare receptors. So that's all. That's all, folks. Any questions? Yep, sure.
Doctor, we're discussing about upregulation and downregulation, isn't it? If an upregulation of agonist and a downregulation of antagonist, would it still have the same results?
What do you think?
Yes.
Prolonged use of an agonist. Prolonged use of an agonist. Do you think the body will upregulate? Are you talking about prolonged use of? Yeah. Are you talking about prolonged use of an agonist?
Yes, doctor.
Yeah. If you have prolonged use of an agonist, it would. Chances are the body will detect that it doesn't need to increase the receptors because there's already a lot of agonists there.
All right.
Okay.
Thank you, doctor.
Yep, you're welcome.
Prof?
Yep. Yes.
Sorry. Sorry for interrupting you. Just a question as well. So I understand that partial agonists can act as competitive antagonists in certain cases, right? To lessen the effect of a full agonist. If you don't mind, could you give
an example?
A few examples of when this would have? Yes, please.
Okay, you'll be hearing it from Dr. Igor. He's coming on to teach you about that in about half an hour. But of course, I can give you an example. All right. Say you have a full agonist. Say you are a houseman in a surgical ward. All right. And a patient has just come back from the OT. He's just had a huge operation and he's in great pain. And so you give him morphine. Morphine is a full agonist. All right. You got that so far?
Yeah.
Okay.
Yeah.
Morphine is a full agonist, and there's only so much of morphine you can give. You cannot increase the dose because you'll get a patient will get adverse effects like vomiting and something will happen to the blood pressure and so on and so forth. Okay. If you forget that morphine is a full agonist, and that when you walk by the patient and the patient says, "Doctor, I'm still in pain. Can you give me something else for my pain?" And if you forget that pentazocine is a partial agonist, and you say, "Yeah, of course I can," and you give him pentazocine, what do you think will be the effect of morphine now? Will it reduce the effect of morphine because now pentazocine has to compete with morphine, or morphine has to compete with pentazocine, right? So patient's pain will increase or decrease?
It will increase.
Exactly, because then pentazocine or partial agonist in the presence of an agonist, a full agonist will act as an antagonist.
Right. Okay.
Right.
All right. Thank you so much for that, Professor.
No problem. Happy to answer any more questions. We still have time. Otherwise, we can stop here, and we can still meet or ask questions through Teams, right? Some of you may find it difficult to understand competitive antagonism, partial agonism, antagonists, and full agonists, and spare receptors, and all sorts of concepts. And not only in pharmacodynamic concepts, but also pharmacokinetic concepts. It takes a while. Okay, it takes a while. Somebody actually asked me about a pharmacokinetic question yesterday, and I'm happy to answer that too. So you can contact me through Teams as well. All right, shall we stop here?
All right, Professor.
All right then. Have a good evening.
Thank you, Doctor.
You're most
Thank
welcome.
you, Doctor.
Thank you, doctor.
Thank you.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Most
Thank you,
welcome.
doctor.
Yeah, take care, all of you. Take care.